next speaker is a consultant rheumatologist and internist with close to 3 decades of experience in internal medicine and about 20 years of experience in rheumatology. She is currently practicing at King's College Hospital, Dubai. She has been trained and practiced at some of London's most recognizable institutions, including King's College, St. George's, Guy's, and St. Thomas's Hospital. She has practiced in Pakistan, in the United Kingdom, and in the United Arab Emirates.
In addition to the clinical training, Dr. Beena Hameed completed a master's degree in clinical research in rheumatology. She has been involved in training and teaching in association with Queen Mary Hospital of London as a clinical lecturer. She has published her research papers in some of the leading international peer-reviewed journals. Ladies and gentlemen, please welcome Dr. Beena Hameed.
Okay, thank you. So thanks again. So I'll be talking on pregnancy in lupus. We all know that lupus is prevalent in women of childbearing age, and pregnancy can have adverse effects on lupus and the woman and the child. So we'll be looking at this talk, understanding how does lupus impact pregnancy or vice versa, and how should we distinguish pregnancy-associated changes with lupus flare, because that sometimes can be very difficult to do so. And then lastly, how to manage lupus in pregnancy. So certainly lupus has impact on pregnancy, not only the mother, but also the fetus. So there are certain complications we should be aware of and should be looking for them actively, and namely obstetric complications such as miscarriage, hypertension, preeclampsia, eclampsia, thrombosis, infections, and thrombocytopenia. And the fetal risks include placental insufficiency resulting in intrauterine growth retardation, preterm, and you also see perinatal mortality due to neonatal lupus and congenital heart disease. So effects on the fetus mainly come because of the presence of anti-Ro and anti-La antibodies in the mother, because it can transfer to the baby through the placenta, and it can result into a neonatal lupus, which is seen in about 10% of the patients would have a classic rash, 20% would have transient cytopenias, and 1/3 of them would have transaminitis. However, as the antibodies clear off the baby's bloodstream, these settle down. And the complete heart block is another problem. It's estimated to be present in 2% of pregnancies of women carrying these antibodies. However, if a woman had a child before with a congenital heart block, and the incidence goes then to up to 18%. And unfortunately, about 20% of infants would die either before they are born, fetus, or after the first year of life, and they might need a permanent pacemaker in half of them. So the maternal complications which occur because of the pregnancy include that half of the patients, the disease flares during pregnancy, and 2/3 of them would have mild to moderate flare, and good 30% would have a severe flare during pregnancy. And the most common flares are cutaneous, musculoskeletal, and hematological. And major risks in this paper were identified as if a woman had an active disease 6 months prior to conception, or they had a multiple flare for a year before the conception, or if somebody stopped their hydroxychloroquine. So when you compare patients with lupus with those who do not have lupus, means control patients, so there is clear increase in the risks of cesarean section. Higher number of them would need cesarean section because of complications. Preterm labor has been reported almost 3 times more in lupus patients as compared to non-lupus patients. Intrauterine growth retardation is almost 4 times higher in lupus patients. Preeclampsia, a large number of them would have almost 1/4 come up with preeclampsia. And again, the rate of eclampsia is very high in lupus patients when you compare them with the control population. So when you compare within lupus cohort, active lupus, or patients who were stable during pregnancy, have a stable controlled disease, you can see the number of term deliveries are achievable higher in patients who were well controlled as compared to active lupus patients. And then premature delivery was more noticeable in active lupus patients. Therapeutic abortions were reported in active lupus. And similarly, spontaneous abortion were higher in active lupus than non-active lupus. So was the stillbirth. And actually, the total, if you look at the total fetal losses, it was about 3/4 of the women in this paper had total fetal loss as compared to 14% of when they were not active. So one has to look for certain predictors which would help us to know whether what would be the outcome of this pregnancy. So in this paper, what they highlighted were that if a woman has been have active disease prior to conception for 6 to 12 months, they certainly falls into high risk group. Similarly, if they have complement levels were low, C3, C4, which indicates the active disease, certainly that again can result in complications. And we have just heard a beautiful talk from Dr. Petrie that the lupus nephritis could be very tricky, and it is very well known, even if the woman has had a lupus nephritis and now she's in the control phase, still the complications and the disease flares are more likely. And of course, if the lupus nephritis is active, there are more complications. Similarly, the presence of anti-Ro, anti-La antibodies, we just saw, can lead on to infant-related complications. Then we had the first talk was about antiphospholipid antibody syndrome. So certainly, there's a high risk of thrombosis and the pregnancy losses associated with this syndrome. And even the presence of antibodies, even if there is no syndrome, but just the antibodies itself can lead on to poor pregnancy outcome. And a woman who already have damages due to the disease, including renal, cardiac, and pulmonary, and certainly it worsens during pregnancy, and it might lead to permanent damage. So this study, PROMISE study, what they compared the woman who had these risk factors with the woman who didn't have the risk factors, and also the control. So you could see clearly any adverse effect is much higher from pregnancy in those who had these risk factors as compared to those who didn't have these risk factors or the control population. Same is for fetal or neonatal death, preterm births, and small for gestational birth. So what are the challenges treating patients, lupus patients in pregnancy? So some of the physiological changes of pregnancy are hard to distinguish from the lupus flare. And we know that uncontrolled lupus leads to poor pregnancy outcomes, and most of the drugs, they do transfer through the placenta into the baby. And some of the drugs, we don't know even the long-term effects. And most of the safety data of these drugs come from case reports or registries, and it is unethical to perform any clinical trials. And the data that comes from the animal studies, we cannot extrapolate them to the human beings. So these are some changes which we can see in a woman who's pregnant as a part of physiological changes in the body. So palmar erythema and facial flush is common, and that's due to the estrogen effect. A woman may develop a pigmented photosensitive rash called melasma, which sometimes can mimic to lupus rash. Generally speaking, there is improvement in the quality of hair during pregnancy, but one does see a hair loss after pregnancy. And we know that hair loss is one of the manifestations of mild lupus. Pulmonary symptoms such as increased respiratory rate, we see early in pregnancy because of the progesterone effect. And then later on, because of the gravid uterus, a woman can be short of breath. One may think of respiratory relapse. Musculoskeletal-wise, in second to third trimester of pregnancy, the relaxin hormone causes the loosening of sacroiliac joint and the pubis that might result into the low back pain. And similarly, later on, the gravid uterus, because of the pressure causing increased lumbar lordosis, may contribute to the back pain. And also, it's been seen some of the women may develop non-inflammatory effusions in the lower limb joints. So there are few things which can keep in mind to differentiate at least preeclampsia and the lupus activity. So first thing is the timing of pregnancy. We know that lupus can flare anytime during pregnancy, and preeclampsia usually happens like 20 to 30 weeks of gestation. And then if woman has had a preeclampsia in the previous pregnancies, there's increased risk of preeclampsia, but it has no impact on the lupus activity. And in case of multifetal gestation, again, increased risk of preeclampsia, but no impact on, in fact, it's not known whether it affects the lupus activity. And if a patient had a history of lupus nephritis, there is increased risk of preeclampsia, and of course, it also impacts the lupus activity during pregnancy. And then if you look at the urinary sediments, it's usually negative in case of preeclampsia, but if patient had a renal disease and it flared during pregnancy, you might see the urinary sediments. For Coombs test or antiplatelet antibodies, even C3, C4 anti-double-stranded DNA antibodies, they are usually negative in patients with just preeclampsia, whereas they might be positive in lupus flare. Serum uric acid may be more than 5.5. This is in this paper, but they didn't see any change in lupus activity. Similarly, urinary calcium was documented low in preeclampsia, but it didn't affect the lupus activity. So these are the few drugs that we use in lupus patients, so we have to be careful. And I'm going to just look at the recent guidelines from British Society of Rheumatology, which were published early this year. So the good news is prednisolone is fine. So we are basically considering these preconception time, first, second, third trimester, and relation to breastfeeding and the paternal exposure. So if you look at the prednisolone, hydroxychloroquine, less than 400 milligrams, dapsone, azathioprine, and cyclosporine and tacrolimus, and IV immunoglobulins. So you can see all of them are green. So essentially means they are quite safe when you consider all these important time of pregnancy, preconception, they are compatible with the breastfeeding, and also parenteral exposure is fine. But cyclophosphamide, the guidance is it's better not to use during pregnancy or preconception, but if there are circumstances which beyond your control, means patient had a high morbidity and the disease is very severe, and you do not have any other options, you can still use these drugs in pregnancy. However, it's not compatible with breastfeeding, and again, parenteral use should be avoided because of the infertility issues. Mycophenolate mofetil, the guideline says you got to stop 6 or more than 6 weeks prior to conception, but it shouldn't be used during pregnancy. It's not compatible with breastfeeding, and yes, parenteral exposure is fine. For methotrexate, previously guidance was you stop 3 months prior conception. Now it's a little bit lenient. It means month or more than 1 month you should stop in the woman who's planning to conceive. Certainly not to be used during pregnancy, not compatible with breastfeeding, and yes, parenteral exposure is fine. So in terms of corticosteroid, that we know that it is partially inactivated by placental 11-beta hydroxylase. So certainly up to a certain dose, it's fine to be used during pregnancy. And in this paper, they said it should be less than 15 milligrams per day during pregnancy if you need it for controlling the woman's disease activity or maintaining the remission. But any dose which is higher than that can cause maternal diabetes, hypertension, preterm, premature rupture of membranes, and then there's some fetal risks. So it should be used at less than 15 milligrams per day. However, you can use, in case of severe flare, as 0.5 to 2 milligrams per kilo, provided you use it at the shortest possible period. Intramuscular, intra-articular, and intravenous glucocorticoid can be used when it's needed during the pregnancy to treat the flares. Fluorinated glucocorticoids should be avoided better because they have higher transplacental passage and they are not inactivated by the placental enzymes. However, you can use them in patients where you need it for the fetal purposes. So there are two important biologics that we're using nowadays, and for them, it's best not to be used because data is not enough. However, again, the guidance says if patient had a severe disease where you don't have any other choice, you might use them. And for the breastfeeding, paternal exposure is fine. So the general medications that we use, safe for paracetamol and conventional anti-inflammatories, but for NSAIDs, they say stop by week 30 because of the patent ductus arteriosus risk. COX-2 inhibitors, no data to support their use, so you don't want to use them. Parenteral exposure is fine. Codeine is fine to use in all situations. Tramadol, not to be used periconception in first trimester, rest of the time is fine. Your low-dose aspirin, clopidogrel, and colchicine is fine to be used in all the 5 situations. So anticoagulation, some of our patients need anticoagulation, but we need to stop warfarin periconception in first trimester because of the teratogenic effects we know. But in exceptional circumstances, they can be used in second, third trimester, fine to breastfeed, and parenteral exposure is fine. Low molecular heparin is fine for all the 5 situations. Novel anticoagulants, again, they're not to be used during pregnancy. However, in terms of breastfeeding, only rivaroxaban has been given the green light. So parenteral exposure is fine. So, because we know that none of unfractionated or low molecular weight heparin crosses placenta, so they are considered to be safe. Throughout pregnancy, warfarin, we just saw because of the congenital anomalies which can happen or risk of hemorrhage, you avoid it during pregnancy if possible. And there's a little amount expresses in milk, so it's fine to breastfeed. Novel anticoagulant, we just saw rivaroxaban only during breastfeeding, but nothing, rest of the indications. So for bisphosphonate, stop 3 months prior, not to be used during pregnancy, no breastfeeding data, parenteral exposure is fine. ACE inhibitors or receptor blockers, you stop prior to conception and first trimester, exceptional circumstances for second and third. Enalapril can be used during breastfeeding and parenteral exposure is fine. Nifedipine, amlodipine, labetalol, methyl-dopa is fine to be used, provided you keep the nifedipine dose less than 90 milligrams per day during pregnancy. So some patients would need these drugs, but then usually those patients who have associated pulmonary hypertension, first of all, we try to avoid pregnancy, in particular in patients who have a severe pulmonary hypertension. So they basically say these drugs should be carefully assessed with a multidisciplinary team approach, and then you decide what to do with them. There's no data for breastfeeding, but the parenteral exposure is fine. So all green on this slide, so quite a few choices for neuropathic pain control, for antidepressants, but they've been found pretty safe in all the 5 situations. So pre-conception counseling, the woman should avoid pregnancy if they have severe pulmonary hypertension, more than 50 millimeter of mercury systolic pulmonary artery pressure, severe restrictive lung disease with forced vital capacity less than 1 liter, advanced renal failure, creatinine level more than 2.8, advanced heart failure, previous HELP syndrome, or severe preeclampsia, stroke within the last 6 months of conception, and severe disease flare within the last 6 of conception. So these women shouldn't get pregnant. The fetal complications, so we just saw Roe and La antibodies can cause congenital heart block. So the guidance is if a woman have had a heart block baby before this pregnancy, then they should have a strict fetal cardiac monitoring beginning from the week 16 to week 26. And then, so my time is over. I think it's probably the last couple of slides left. So it should be less strict if there is no prior pregnancy with a heart block. So only first and second degree of heart block that you give dexamethasone 4 milligrams a day. There's no evidence it works for the complete heart block. You need then a pacemaker. So usually if flare happens postpartum, happens within the first 3 months of 60 to 90% of cases. You restart treatment as soon as possible, manage flare accordingly, and breastfeeding drugs we have just seen. So contraception is another important issue postpartum. So patients who have lupus and antiphospholipid antibody syndrome, you go for the intrauterine device. If they have a stable SLE with no antiphospholipid antibody syndrome or antibodies, you go for combined hormonal treatment. And if they have APL, just the antibodies positive, but no syndrome, you can give them progesterone only preparation. So in conclusion, careful planning of pregnancy and pregnancy counseling, keeping in mind the safe drugs and strict monitoring would improve the pregnancy outcome. And I think that my time is over. Thank you very much.
Thank you, Dr. Beena. It has been a pleasure having you with us today. Ladies and gentlemen, that won't be the last we see of Dr. Beena Hameed for the day. She will be joining us again in the afternoon, inshallah. May I remind the speakers, for their convenience and ease of viewing, we have placed screens right in front of the stage so they can have a good view of their presentations.